Hello, everyone. My name is McCammon, and I appreciate everybody joining us. I'm going to get started in about 2 to 5 minutes, just letting some other people sign in. For people who are familiar with Zoom, there is a chat function that you'll be able to put questions in. I think everybody is muted except for me, is what I was told. And so what we'll do is, if you have any questions, you can go to the top of the screen, or sometimes at the bottom. On my computer right now, it's at the top. There is a chat function. You click the chat and you can ask questions. The presentation will be about 20 to 30 minutes. And then we'll have a short time for questions, again, through the chat function. As you can imagine, having so many people on the call, it can be quite difficult. And therefore, we won't be answering individual questions except for in the chat function. And yeah. So as I said, I'm going to wait about 2 more minutes just to give some people to sign in. I am very punctual. That's why we're here. Some people who see me in the office may argue that statement. But I try to be very punctual, I guess I should say. I usually show up on time. So we're going to do our best to stay on time and respect everybody's evening. I also need to apologize. I have 3 dogs, and so hopefully they're not barking. I've hidden myself in a small room, but hopefully you won't hear any dogs. So it appears the number of participants has remained stable joining. So I'll say we'll get started. Again, to respect everybody's time. Once again, I want to thank everybody for joining us. My name is McCammon. I'm a urologist at Urology Virginia. I'm also a urologist in the Department of Urology at Eastern Virginia Medical School, and the chairman of the department. And I have a special interest in male urinary incontinence. It's something that I feel very fortunate to be able to help men with. I was telling a young student yesterday, it's probably some of the happiest patients I've taken care of. And so hopefully I can help educate you and answer some questions you may have. As you may know, tonight's presentation is supported by SURF, which is the Schellhammer Urologic Research Foundation. The Schellhammer Urologic Research Foundation actually started probably 20 or 30 years ago. It was initially called the Foundation of Urologic Research. It was started by a gentleman by the name of Paul Schellhammer. And it provides excellence in research, education, and compassionate innovation in healthcare. Our mission is to improve the urologic care in our community and beyond through excellence in education, compassion, innovative healthcare and research. And SURF has continued to provide support for our academics at our residency, to provide support for education, as well as some international humanitarian work. So what we're here to talk about tonight is male stress urinary incontinence. And stress incontinence is the leakage of urine when you laugh, cough, sneeze, run, jump, dance, do any type of activity. It's not emotional stress, which sometimes people always think it is. And it's not the, I have to get to the bathroom right away, or I'm leaking on the way to the bathroom. That's overactive bladder and urgent incontinence. There's a large number of men that suffer from stress incontinence, and nearly 1 in 20 men over the age of 20 have some form of incontinence at times. Just to kind of go through some of the anatomy, here is the bladder. This is the prostate. This is the sphincter. So you have 2 sphincters that keep you dry. You have an internal sphincter, which is damaged internal sphincters here, you cannot use this to control it or tighten it. This is actually damaged with most prostatectomies. And then you have the external sphincter, which is marked here. And that's the one that you can squeeze and contract. And that's the one that you can do exercises with to tighten it up. This is a common problem. As you see, 1 in 10 American men over the age of 60 have some form of incontinence. So this is something that we see quite frequently and do take care of quite often. The urination process. So the bladder fills. It's pretty simple. I tell people all the time, I do this part of urology because I don't have to think too much. The bladder has 2 jobs. It holds urine and it pushes urine out. So the bladder will fill with urination. When the bladder is full, then the patient will feel the urge to go to the bathroom. They'll relax their sphincter and then they'll void. Leakage, again, is when one of those sphincters just doesn't control the urethra and the patient's allowed to leak. So where does stress urinary incontinence come from in men? Well, most of the time, it's following prostate surgery. It can be prostate cancer surgery, and rarely it can be surgery from benign enlargement of the prostate, or BPH. That surgery has an incidence of about 1 or 2% of incontinence more than a year. But if you have your prostate removed from prostate cancer surgery, that actually, the incidence is, as you can see on the slide, 9 to 16% have incontinence still 1 year after treatment. Now, that's a little bit misleading because if you look at patient-reported outcomes, actually about 40% of patients will report having some type of incontinence after this surgery, even longer, but it's not as frequent. About 9 to 10% of men will actually have significant incontinence where they're wearing a pad or more. And those are the patients that sometimes will come in and require or ask for treatment. It can also be the result of neurologic disorders, again, enlarged prostate, radiation, or trauma can also cause stress incontinence. The reason that I actually enjoy taking care of these patients is not because of the causes that you see here, but because it actually can truly improve somebody's quality of life. Incontinence actually increases the risk of depression. It increases social isolation. It actually causes patients not to be active and affects their weight. It affects their relationships. A number of my patients have come in with their spouses or come in without them and said, you know, our relationship is truly different than it was before because of this incontinence. The patients won't go exercise. They won't go to a friend's house. They won't go dancing. And the other thing I tell patients all the time is I don't do quantity of life surgery. I do quality of life surgery. And I truly believe that if you're not enjoying your quality of life while we're here, we should do something to fix that if we can. There's a study that was done years ago that showed 26% of patients will limit their activities, again, because of incontinence. 36% will change their lifestyle. And up to 45% really affects their confidence in their social life. This is a study that we did actually with us too. And what we did was we looked at men who had incontinence, and we looked at what they felt about this. Now, these were men that wore more than 1 pad a day. But as you can see on the slide, 50% of patients would do anything to cure their incontinence. Rather, a day rarely goes by where they don't think about it, over 65%. Major impact on their quality of life, 40%. So this is truly something that can affect people's quality of life. It can affect your activity. And the nice thing, there are things that can be done for it if that's what you would like to proceed on. The other thing that I think is really interesting, I guess, is the amount of money that's spent in the United States. Now, if you can see on this study, this was a study that was done in 1995. So this is an older study. But $26 billion was spent on urinary incontinence. And unfortunately, almost half of that was spent on routine care. Now, what that means is pads for protection, clamps, changing your clothes, washing. And obviously, you need a statistician and someone with health economy background to come up with this. But this is quite impressive, the amount of money that was spent. This has been redone again, and actually the numbers are even higher now as we've gone further along. Well, what can we do for stress incontinence in men who have had prostate cancer? So as you know, So here's a picture of the bladder. Here's the prostate. When you have a prostatectomy, when you have the prostate removed for cancer, the prostate's excised, and then the bladder is sewn back to the urethra. The surgeon will do everything they can to continue to promote the external sphincter and not damage it. And they'll try to keep the internal sphincter as well. But again, it can be quite difficult. There's some really good studies that show that the reason for incontinence after surgery, there are patient factors. There are obviously surgeon factors as well that can lead to the risk. And you do need to make, or you would want to make sure that your surgeon is doing a number of these operations before you do. And I'm happy to say that most or all my partners actually do quite a few of these. And so I'm confident to say my prostatectomy partners do a wonderful job. But again, as you can see, there's a number of patients that have incontinence. We're going to skip this because again, it's very similar. So what can we do for treatment options? Well, almost everybody that I see comes in and they've already limited their fluid intake. They've pretty much stopped drinking water. They plan to go to the restroom. If you look at the AUA, which is the American Urologic Association, there are guidelines now for the treatment of prostate cancer. And the first treatment should be pelvic floor physical therapy. A lot of people will call those Kegel exercises. Our physical therapists don't really like that term, but doing physical therapy to try to strengthen those muscles will actually increase the time to cure. It doesn't always fix everybody, unfortunately. And then there's obviously things that men can use to kind of cope and protect themselves. There are pads, diapers, you can wear a catheter, you can have a condom catheter, which is a catheter on the outside of the penis, or you can put a clamp on the penis. Which is quite uncomfortable. And I've seen some significant complications, but you can see this clamp here. You can imagine squeezing the penis. There are, again, patients who use it and do well, but again, that can lead to erosion of the skin and infections and things. These coping mechanisms can be quite expensive as well. This can lead up to, there was a study that showed up to $7,000 a year can be spent on these. And a lot of patients, are worried about the smell and the discomfort, or if it gets full. And so there are some concerns patients will have with that. So what are the solutions, or what are the treatment options? Well, there's a male sling. This is a device that's placed underneath the urethra, and it has a relatively good success rate for patients with mild to moderate incontinence. We've had a large experience with this, and about 75 to 80% of our men who are 1 or 2 pads a day have actually done very, very well and are quote unquote dry or minimal incontinence, so a couple drops a day. This is an operation that doesn't need to be, you don't need to do anything to urinate. You void normally after it's done. You do need to behave yourself after the surgery for about 6 weeks so you don't loosen the sling, but it's done as an outpatient procedure. And as you can see at the bottom of the slide, 92% of patients would undergo the procedure again. And here is a small diagram of the sling. Again, it sits underneath the urethra. It's made through a small incision underneath the scrotum and then 2 small incisions in your groin. And again, it kind of pushes the urethra against the pubic bone and stops the leakage of urine. But the gold standard, and so the sling has been around for since 2006. It was FDA approved in 2006, so it's been around for almost 15 years at this point. It came out at the middle of 2006, so it's been around for about 15 years in the United States. It was in Europe for a couple months before it came to the States. But the gold standard for stress incontinence is an artificial urinary sphincter. This product was actually initially developed over 40 years ago, and it's been around for quite some time. It has minimal changes over the last 20 years. They've had some minor variation, but the biggest changes the last time was in 1986. So this is the device that we know well. We know what will happen to it. We know how it will work, and we can tell you kind of where your outcomes will be. So this is what the device looks like. It's all underneath the skin. There's a pump in the scrotum. There's a cuff that's wrapped around the urethra. And then there's a little pressure regulating balloon that's up in the the abdomen. How the device works. The device is always squeezing. So as you can see here, the cuff is closed. When the patient wants to urinate, he will squeeze this pump. This pump will transfer the saline in the cuff into the reservoir. It'll have about 30 to 60 seconds to urinate. And then the reservoir will slowly push the saline back into the cuff and squeeze off the channel again. So again, the patient doesn't leak. This is, and we'll see some slides in a second, the success rate with this is about 90 to 94%. About 90 to 94% of patients would refer it to a friend or recommend it again. It's done as an outpatient. Anytime you ask a surgeon, we're always going to tell you we make small incisions, but the incisions are about 3 to 4 centimeters, so 1.5 to 2 inches. There's an incision underneath the scrotum where we will put the cuff, and then there's an incision in the groin where we'll put the pump and the reservoir. I usually keep patients in the hospital overnight, as all of the surgeons at Urology Virginia do. We leave a catheter overnight, and then we send you home the next morning without the catheter. We'll see you in the office usually in about 3 weeks just to make sure everything looks okay. And then we activate the sphincter in the office, and we do that by squeezing the pump. It's not a terribly uncomfortable procedure. Every once in a while, maybe a little bit harder to do, but most patients tolerate it very well. I think I activated 2 or 3 in the office yesterday, and with no significant discomfort. After the surgery, the patient should refrain from any strenuous activity, no motorcycle riding, bicycle riding, or horseback riding for about 4 to 6 months, because you don't want to put pressure where that incision was. If you look at patient satisfaction, patients in generally are very satisfied with this. 94% of patients are satisfied with their device. 90% are satisfied with their long-term device, which is obviously very important because you can be satisfied for a couple of days, but it's really important to be satisfied 5 or 10 years down the road. Most patients would have the procedure again, and 94% of them would recommend it to a friend. So this is something that patients do very well with and actually are quite happy with the results. As I was saying earlier, I was telling one of our students, these are some of my happier patients that I take care of, and it's quite rewarding at times to see these patients. One of the questions we always get is, does insurance cover this? And yes, it does. It's covered by Medicare, and it's covered by every insurance company in the area, and I think in the country. I don't know of anybody that doesn't cover it. If there is any issues, the company that makes this actually goes out of their way, and they have somebody that works for them that helps them get it approved. But in all honesty, we've never had any issues getting this approved. Here's just a couple patients who have talked about what their experience was. One gentleman said it took him from 9 pads to 1, and I think that's really important, because when I talk to my patients, we consider success as 1 pad. So if a patient comes in post-op and says, well, I'm down to 1 pad, that's actually considered successful. Would I like everybody to be dry? Of course. But you don't want to make the cuff too tight, because that can lead to other problems. And so 60% of patients are dry, but a number of patients will still wear a small pad because of a few drips or drops. As you can see, the other gentleman just said he felt great after surgery, was able to walk around. And it's really not that, in general, not that painful of a surgery. Most patients do well. Again, I'm the surgeon who's telling you that, so you always have to take with a grain of salt if the physician says the pain is minimal, but truly the pain is minimal. We have some of our own patients who have been patient advocates, have gone out and give talks, and are happy to talk to patients that are possibly interested in this type of treatment as well. So this is a issue that we can treat. It truly does change patient satisfaction. As you saw when we first started, the quality of life issues can really be detrimental to enjoying life and enjoying what you want to do. And this truly can take you and make those things better and give you back the life that you were hoping. it's something that a lot of men don't think about when they're being talked to about their cancer treatment. The biggest question they have is what's best for my cancer? And they don't always hear that the side effects can be incontinence or erectile dysfunction. But they are huge issues that can be treated if they become a problem. As the slide said, nobody knows that you have these devices in. No one would ever know. You don't need anything special to go through the airports. They're truly concealed, and there's no metal, so no issues with airports. But as we say, nothing's ever perfect, and there can be problems associated with things. So with regards to the male sling, sometimes it won't work. The success rates are lower than a sphincter, and sometimes it can be too tight and you can't urinate. The postoperative pain and irritation at the wound sites are actually pretty small. The development of overactive bladder symptoms, though, can happen with a sling, and those can be difficult to treat. With the artificial sphincter, again, it's a mechanical device, and I tell every patient that we do a sphincter on, they will come back and have a revision at some point in their life. It's usually about 10 or about 5 or 15 years after surgery, on average of about 10 or 12. And so patients will come back and get a revision done. There's one of 4 things that will happen to the sphincter. The device will either break. It's a mechanical device, so it can break. It can erode into the urethra. So the one thing that people who have a sphincter need to know and need to be aware of is if they ever need a catheter, they should have a urologist place the catheter. So if you're going to have surgery for something, you should have a urologist place a catheter. Some patients will wear a medical alert bracelet so that if they're incapacitated and they can't talk, that the doctors that see them will be able to know. With our current EMR that we're having, our medical records, most medical records can be seen anywhere around the country. And so that will hopefully help alleviate that problem. It can cause urinary retention, although that's extremely rare. You can get an infection of the device. It's a foreign body, and infection rates are about 1%. And then the other thing that can happen or will happen is the leakage will come back at some point. This is squeezing the urethra, and that's a muscle around the urethra, and that muscle will get thinner. And so therefore it won't be closing as well, and therefore the patients will have leakage. Here's a website. It's called fixincontinence.com. It talks about all the different solutions for bladder leakage. I can type it in the chat when I'm done so that you can go to the website and look. But it does talk about all different type of treatment options and things that can be done. Finally, just one more shout out for SURF. SURF, we have 4 different arms. As I said, patient education, some seminars like this. We've done bladder cancer, prostate cancer, and we're continuing to do these going forward. We have provided some support for patients that did not have insurance or couldn't afford to come over from the Eastern Shore. We have provided some support for those patients. SURF has provided support for humanitarian efforts. I spend some time doing some humanitarian work, and SURF has been kind enough to support our trainees to come with me. They don't support my travel, but they support our trainees, which is a great experience for them to see how lucky we are to practice in this country. And then finally, it does help foster some research. It's had supported research for years, supports some of our residents and their opportunities to develop research, to learn some new things, and actually then to travel and present their research at other places. So I want to thank SURF, and if you're interested in donating to SURF, I'll type the website in because I don't think I actually have it on a slide. Here is our website for the Urology of Virginia. Paul Schellhammer is in the picture here. He is the S in SURF and who started the research organization years ago. And again, our number is 757-457-5100 if you have any, if you'd like to make an appointment. As I said, I'm happy to go answer any questions. I'll read the question that are in the chat. For people who have joined a little bit later, there is a chat function, and you're more than welcome to type in. The question is, the patient had a prostatectomy in 2008, had a sling procedure. Unfortunately, it appears not to be successful. And the question is, would he be a candidate for artificial urinary sphincter? And though, yes, you would be. That is the next step. If the sling didn't work, then a artificial urinary sphincter is the next option that we would do. The other question is, I presented 2 solutions. Are there any other alternatives? And yes, there are. There are 2 other FDA alternatives or options that are available. So the first is what's called a bulking agent. Bulking agents are done through a cystoscope, and we inject medicine into the urethra to kind of bulk it up. Unfortunately, the success rates have been pretty poor, and therefore it's not really recommended. We have some relatively good success rate in patients who have had slings, who have mild incontinence after the sling. But besides that, the success rates are not very good. The other question was, or the other option is, there's a balloon that can be placed next to the urethra. It has been FDA approved. It was not, if you look at the AUA guidelines, it was not really recommended. And also the complication rates are a little bit higher, and success rates are lower than a sphincter and a sling. And that's why I did not present those, because they're not very good options. So truly the only 2 options that most urologists do are a sling and a sphincter. The next question was, I had a prostatectomy 4 years ago, resolution of the incontinence. Then a year later, I had to have radiation. I'm sorry, I'm just scrolling down. Now uses 1 or 2 pads a day. Will the sling work after radiation? The sling is actually not recommended after radiation. You could consider it if you have 1 pad and it's just a smaller pad, but if it's a moderate pad that's significantly wet, or 1 large pad that's wet, the recommendation would be to do an artificial urinary sphincter. The success rates appear to be equal in patients who have radiation, although the revision rates may be a little bit earlier. So you may have to have a revision surgery sooner than if you hadn't had radiation, but the success rates are the same. The next question is, I had a radical prostatectomy, gained bladder control, then had proton therapy and lost bladder control. Unfortunately, that happens quite frequently. Patients will do well, and then sorry, I was just reading another chat as I was chatting. What will happen is they'll do well, and then radiation will cause a damage to the muscles, and they'll have leakage again. And again, a sphincter is a good option for that. To go back to that gentleman's question, the doc said we scarred you up pretty good down there. So anybody who has radiation, we usually end up doing a cystoscopy prior to surgery, just to make sure there is no significant scarring, because that can affect outcomes. Another question is a very good question about how soon would we consider to do treatment. So the recommended guidelines are, you should do this at least 6 months, if not 12 months after your prostate surgery. So we would consider, if you're severely incontinent at 6 months, the chance of you getting a significant improvement is pretty small, and we would consider doing something at that point. But if you were improving with your physical therapy, or you had more mild incontinence, we would not offer a surgical option at that point. Does radiation also have post-treatment effects? I could spend my whole career taking care of radiation complications, and there's quite a number of them. The only other thing I will say about, well, not only thing, but the other thing I will say about radiation is the radiation effects last and continue to worsen for years. It's one thing that, years ago, we were not living as long as we are now. And patients who get radiation, they'd be around 5 or 10 years, and unfortunately would succumb to something else. Now we're very lucky to have our healthcare system and the medicines and things. And so therefore, we are living longer, but that means that radiation side effects, including blood in the urine and hematuria and clot retention and overactive bladder, have all become more of an issue. Gentleman says he had a prostatectomy a year ago, but due to fluid retention, he's taking Lasix. That will, obviously, decreasing your Lasix will actually make your incontinence better because it's just going to hopefully decrease the amount of fluid. Any work limitations long-term after the surgeries? No. After 6 weeks, everything's the same. For the first 4 to 6 weeks after surgery, no lifting or straining or any type along those aspects. Is there any difference in side effects between external beam radiation therapy and proton therapy? I am not a prostate cancer expert, so I'm going to pass on that question. I will say that I'm not sure there's as big of a difference in proton as people claim. I have a lot of patients who have had proton therapy, and I've had some very significant complications that I've had to take care of for them. So I think there are complications with both, and I don't think there's a true answer yet on which is better or worse. The next is, I had my prostate cancer was removed in February of 2016, still wearing pads during the day and at night, sometimes has to use diapers and changes those at night. So the best option for that person would be an artificial urinary sphincter. The other thing is, he asked a little bit of, well, I'm assuming asking about erectile function. I'm a proponent of penile rehab. Penile rehab is using either some type of oral medication or a vacuum pump to kind of stimulate the penis. As most men know, after they've had a prostatectomy, they complain of loss of length. It's actually not because the prostate's removed, it's because you're not getting your nighttime erections. You're not getting the stretching of the penis as you did before, and therefore the prostate will shrink. If you don't use it, you lose it. So I'm a big proponent of using a vacuum pump or something to help you keep the length of your erections, so that if you desire to do something, and for erectile dysfunction, there's oral medication, there are vacuum pumps, penile injections, and obviously a penile prosthesis that can be used. Do I recommend Lasix to reduce fluid retention? So that's truly something that you need to talk to your cardiologist or your nephrologist about. That is more along the lines of heart failure. And if you're having fluid retention, you truly need to follow up with your primary care or cardiologist regarding that. The other question is, does alcohol consumption affect incontinence? Alcohol is a muscle relaxant. So if you do have alcohol, it can cause your muscles to relax, and you can have some difficulty with incontinence from that. It also, red wine actually, it has a chemical in it that relaxes your bladder. So it can give you a little bit of relaxation of the bladder, which may help the overactive bladder symptoms. A gentleman needs hernia surgery. Yes, we would be able to do the sling surgery at the time of hernia. We have done that a couple times, not as frequently. A lot of times our general surgeons would rather not do it at the same time, but we could if that was needed. So a question is, the patient had tried some things, injections and a pump. There is a penile prosthesis that you could try that does help with regards to erections. The next question is, do seed implants affect incontinence? So seeds are a form of radiation. Radiation can cause some overactive bladder symptoms. It does have probably a lower risk than external beam radiation therapy, but it can lead to some overactive bladder symptoms. I see 3 other questions that I missed in the question and answer, which I apologize. I didn't even know that was there. Thank goodness I saw it light up. What type of prostatectomy results in less incontinence and or impotence, and what percentage of each type does our company experience? So I don't know the exact numbers because I don't do the prostate surgery, and therefore I would suggest talking to our partners. But we almost only do robotic prostatectomies at this point. I think that's the standard of care in the United States. And the continence and potency are equal, or incontinence and erectile dysfunction are equal depending on what procedure you do. And it's probably better with the robotic surgery at this point. When it first came out, that was one of the initial concerns. Is initially there was a learning curve, but the number of robotic prostatectomies that are done is significant. Which is best, proton therapy or surgery? It truly depends on your stage of disease, your PSA, your Gleason score, and that should be something that you discuss with your urologist to decide about treatment. And then our surgeons have done the nerve to improve the sensation. Most people that I know of in the country, and I'll be honest, again, I don't do prostatectomies, but most of the people that I know that do a lot of prostatectomies have abandoned that because the success rates were not that great, and therefore they've kind of abandoned that procedure. I think, is a sling surgery done with a robotic? No. There was a study done 10 years ago that looked at doing the sling at the time of the prostate surgery. And actually what that showed was you're increasing the cost of healthcare significantly because you're putting in slings in 90% of patients who don't need it. And so therefore, it was felt that that wasn't a good idea. Also, there's a small risk of not being able to urinate afterwards. And therefore, the last thing we want to do is give you a complication. And so it's not recommended that you would do it at the same time. I'm happy to answer any other questions if anybody has any questions. Here we go. Difference in side effects between IRBT and proton therapy. Again, I am not I don't do prostate cancer treatment. I don't think the side effects are as different as they are described. And I've seen significant side effects from both treatment options. And therefore, I would ask you to discuss with your urologist who's taking care of you. Are there any age limits? Actually, the oldest gentleman that I did a artificial urinary sphincter on was 94. And he actually did very well. He lived for 3 more years. Obviously, it's not age, it's health. And if you're healthy and doing well, I don't think there should be a limit in telling you you can't enjoy your quality of life. And so it's pretty rare that we do for somebody that age, but we operate on a number of patients in their 80s for this. What's the incidence of incontinence with with radiation? It's pretty low. If you look at quality of life, radiation does cause a lower risk of incontinence than compared to prostatectomy. And then you would have to, the question is, do we take samples of the nerves and send them for biopsy and wait for the answers? You would have to ask the surgeons. I apologize. I'm not usually in the room when they're doing their prostate surgery. I'm trying to do my surgeries or in my office seeing patients. So I don't think that's what they do, but I don't want to tell you that they don't if they truly do that. So that would be something they would have to address with them. Well, if we're done, I don't want to stand here and stare at the computer, listen to myself talk all night. I truly appreciate you spending a little bit of time with me. I hope this was educational, and I hope this was beneficial. Please be on the lookout. SURF will be sending emails out for other educational experiences. With some of these questions, I will probably ask some of my partners to talk about prostate cancer treatment and maybe talk about what's the right treatment comparing external beam, proton, and surgery. There is another question. Are the sling and artificial sphincter performed at the hospital or CRSC, Chesapeake Regional Surgery Center? I think they're currently performed at the hospital. At least that's where they're currently performed now. I'll stay on for a few more minutes, just in case another question comes in, but I truly appreciate you taking the time, and again, be on the lookout. I'll try to see if we can do a talk on erectile function, since that appeared to be a question that people had. And again, I'll reach out to organizers and see if we can do one on treatment of localized prostate cancer and help with that. Yes, I do. I do both of these options. I do the sphincters and the slings. And yes, in our group, I know Robert Given does the brachytherapy or the seed therapy. Dr. Liu does, and I know Dr. Rawls does. There may be others that do, but I don't want to tell you for sure and then be wrong. But I know those three gentlemen do for sure. The question, can you get a copy of your surgery from 2005? You would have to ask the surgeon. I really don't know, sir. I'm assuming that it's not available this far down the road, but it sure may be. But I would bet money that it's probably not 15 years later. Well, again, is there any rate? So seeds, comment on seed therapy. So if you look at quality of life questionnaires from patients, seeds, brachytherapy, patients will have a slightly higher risk of overactive bladder than a prostatectomy, but actually probably lower than external beam radiation therapy, less stress incontinence, and less erectile dysfunction. They do have some bowel proctitis-like symptoms, urgency of bowel. Will the recording be available? I sure hope so. I will find out from somebody and make sure that we put it online. So someone asked if there's a pill that helps with incontinence, or someone had a partner or a friend that was put on a pill. So when we look at medications, and I apologize, I didn't talk about those. There are, again, two different types of incontinence. So you hear about all the overactive medicines and overactive bladder medicines. Those will treat I have to get to the bathroom right away. I leak on the way to the bathroom. And those don't help stress incontinence. The treatment for stress incontinence, there are two drugs that could be used. There's an antidepressant that can be used because it does cause some tightening of the sphincter. It can also relax the bladder. Probably 20-25% of patients will get a response to that. So not a lot of patients, but it can. And then there's also a medicine that tightens the sphincter. All cold medicines can tighten the sphincter. Unfortunately, they also can increase your blood pressure. And so the one that was used consistently for patients with stress incontinence, men or women, was actually taken off the market because it increased the risk of strokes as well. And in general, patients that have had a prostatectomy or a little bit older have a risk of high blood pressure. And so it's not something that we use frequently, because the last thing we want to do is obviously cause somebody to have high blood pressure and the sequelae associated with that. Very glad to hear one of the questions. The patient said that he had no side effects after his robotic surgery, and his PSA has been 0 ever since. So I think that's a resounding commercial for surgical procedures, and glad to hear that you're doing well, sir. Well, again, I want to thank everybody for taking your evening and spending it with me. If you have any questions, please don't hesitate to talk to your urologist in our group or whoever's group it is. And thank you very much. And if you consider checking out the SURF website, that would be great. Hope you have a good evening and have a good summer. Please stay safe.